Good morning, good afternoon. I welcome you all to this webinar that is jointly organized by GARDP and the World Health Organization. Today we are talking about saving children's lives, treating neonatal sepsis. Sepsis is one of the serious worldwide health threats of our time. It affects individuals of any sex, of any age, but it does disproportionately affect vulnerable populations such as pregnant women, neonates, young children, older persons, and individuals with underlying chronic conditions. So because today is World Children's Day, Universal Children's Day actually, we are going to focus on how to treat neonatal sepsis. And we are having a very impressive panel with us. And I'm going to introduce the speakers later when they are going to make their presentations. Why are we focusing on neonatal sepsis? Because we know from the recently published global report on the epidemiology and burden of sepsis that an estimated 15% of all neonatal sepsis deaths globally were due to sepsis with the highest overall incidence in low-income countries. And we do estimate as WHO that 400,000 to 700,000 annual deaths worldwide are due to neonatal sepsis. And we also know that the vast majority of these deaths are actually avoidable, and that is what we are going to work against. So before we come to the actual presentations, we would like to show you actually a video, and I would like you to stay with us, even if you maybe for technical problems cannot see the video. It's only 2 minutes, so please stay with us. And please also use the function of sending us your questions, because this is meant to be an interactive discussion with the audience. And you can see on this slide how to actually submit the questions. We are going to show this slide later again. And we would very much welcome your input to this webinar. And now, please let us watch this short video on neonatal sepsis that was produced by GARDP.
Raise me up from the ground. I'll take you down and build my walls around, so I can't hear a sound. There's no escaping out. Makes no sense hiding. Shadows surround this house. Thunder and lightning. Thunder and lightning. Energy's rising. Your aura is frightening. Heavens colliding. Like thunder and lightning.
Now we are coming to our first very short presentation, and I welcome Dr. Manika Balasigaram. He's the Executive Director of GARDP. GARDP is a foundation that is developing new antibiotics, in particular to treat neonatal sepsis. Manika is a trained medical doctor, and he has years of experience working in the field, but also conducting research in low-income settings, and he has managed clinical trials himself. So welcome, Manika. I'm very much looking forward to listen to you. Over to you.
Thank you very much, Peter. And I'll just give a very quick overview of the work of GARD-P in this area in neonatal sepsis, why we do this work and what we are doing. So first of all, why are we focusing on children and newborns? In fact, this is one of the earliest programs that GARD-P actually started when we were set up by WHO and the Drugs for Neglected Diseases back in 2016. And in fact, we felt that right at the outset, we needed to prioritize neonatal sepsis. Up to 3 million newborns are diagnosed with neonatal sepsis, which, as Peter mentioned, is a life-threatening bloodstream infection. And this causes significant morbidity and mortality. And unfortunately, there are very few antibiotics that are actually licensed for use in this vulnerable group. It's important to remember that prior to the antibiotic era, case reports that we find in the literature show a mortality of about 90% without antibiotics. So antibiotics are in fact absolutely critical in the treatment of neonatal sepsis. And as I mentioned, children and neonates are actually underrepresented if you look at the actual antibiotics in the market, but that is also the case when we look at what's under development or new antibiotics that have recently come onto the market. And in fact, there are very few antibiotic development programs that are undergoing focusing on neonates and young children. And this is obviously in spite of regulatory agencies requiring manufacturers to evaluate new antibiotics for use in the pediatric age group. So as mentioned in the video, GARD-P is actually embarking on a neonatal program with partners. And one of the most important studies that we've recently completed is a very large observational studies that was conducted in numerous countries across the world with several partners. And we will be touching upon the experiences of GARD-P and our partners in different countries in conducting this study. But I would just like to give very top level findings of the study that was conducted. We recruited over 3,000 babies, and basically this was both a clinical and microbiological study. And in fact, we did evaluate clinical signs and symptoms, as well as clinical outcomes, as well as collected appropriate samples for microbiology and whole genome sequencing. And in fact, the study did actually find and did try to identify what were the key symptoms and signs of babies diagnosed with neonatal sepsis. And this is, of course, notoriously difficult. We did, in fact, identify probably about a bacteria in about 20% of babies enrolled. This is not atypical. Blood cultures typically don't give high yield for neonates. And in fact, also, we did also identify and see that there was bacterial resistance, although this differed across different parts of the world in different sites. This is not surprising. However, unfortunately, we did see fairly high levels of resistance to mainline treatments such as ampicillin, gentamicin in several locations. This, again, is not a surprise and has been already reported in previous studies. There was variability of antibiotic use across different regions and countries, and this is almost certainly because clinicians themselves recognize that they are dealing with probably, I would say, different challenges in different parts of the world. And we are seeing escalation to more heavy-duty antibiotics, including carbapenems, in several parts of the world. And this, of course, is of concern, but again, something that we understand why clinicians need to do. Of course, access to antibiotics in certain regions is a challenge. And this has two effects. This may limit the amount of antibiotics available for certain sites. And obviously, there are limitations on what is the ideal treatments that could be provided for children. But I think, clearly from the study, we understand that the next steps will be that we need to, in fact, conduct more strategic public health trials, basically to assess current and possible new combination regimens to address neonatal sepsis. And this could be including combinations of older existing drugs that could tackle certain drug-resistant bacteria. So I'd just like to highlight where we've done the study and thank all the partners who were involved in this extremely important effort. And it's quite phenomenal that we've managed to complete the study in this relatively short space of time. And this is really due to the dedication and hard work of all our country partners across the world. So a big thank you and recognition to all of them. But I would just like to close by basically saying that GARDP is indeed now embarking and continuing, I would say, its neonatal sepsis program. And there are several components to that. Of note, we have recently completed a clinical trial on fosfomycin to establish a safe dose for use in neonates. And this study will be reported fairly shortly. It is now completed and closed, and it's now in the reporting phase. We are also now developing a new study that will assess 3 potential combinations of antibiotics, older antibiotics, as well as other existing treatments that are available. We will be looking at an innovative trial design to conduct this study, and we hope to be launching this study next year. And this is really to look at how we can replace empiric regimens, a standard regimen such as ampicillin gentamicin, which remains the current WHO recommended treatment for sepsis, but which we all recognize has limitations due to increasing resistance. And we are, of course, also looking at new chemical entities. We have recently partnered with Venatorix Pharmaceuticals on a novel antibiotic, kefapine taniborbactam, and we will be launching the pediatric development of this program over the course of next year with our partner Venatorix. So there's quite a lot going on. We hope to do more over time, but indeed the neonatal sepsis observational study has been a very important springboard to get all of this work started, both in giving us background information, understanding the scale of the problem, looking at potential treatment options, but also I think identifying a network of really solid sites and partners who will be able to conduct future neonatal trials to really improve outcomes for babies in the future. So I would like to thank all our donors who've really made all of this work possible, and thank you all for listening.
Thank you very much, Manika, for this overview. I'm really very impressed by the observational study you have done. 3,200 babies in 19 different hospitals in 11 different countries, and we have seen the list. There's so many. I mean, the countries are really countries all over the world. So that is really impressive, and it's also really key that GARDP as a foundation that you are really, I mean, focusing on developing new treatments for neonatal infections, because this is an area where the commercial research is not going to focus on. I would like now to introduce Dr. Borna Nyoka. She's joining us from Kenya, and Borna is a clinical researcher and public health specialist. She is the Senior Clinical Project Manager at Drugs for Neglected Disease Initiative, which is a bit of a similar organization than GARDP. GARDP was set up by DNDi and WHO, actually. And Borna is actually the clinical trial manager for the observational study in Kenya and Uganda. And she's going to talk to us about neonatal sepsis in Kenya, challenges and solutions. So please, Borna, over to you.
Thank you for the introduction, Peter. So I'm going to be talking about neonatal sepsis in Kenya and some of the challenges we have faced and possible solutions or recommendations in terms of neonatal sepsis within this context. If we were to look at neonatal sepsis and neonatal mortality in Kenya, we do know that neonatal sepsis contributes to 10 to 20% of deaths in this age group. And most of these deaths occur in resource-limited areas, such as in Kenya. In 2018, we see that the neonatal mortality rate for Kenya was 19.6 deaths per 1,000 live deaths. So definitely these are not meeting our SDG goals. And we see in most of the local studies that have been done that we have a predominance of gram-negative over the gram-positive organisms. It has been mentioned for the WHO, they provide guidelines on the use of ampicillin gentamicin or penicillin gentamicin, which is also actually part of the national guidelines for the treatment of neonatal sepsis in Kenya. But from local data, we see that we have very high resistance against these recommended drugs, with 82.9% resistance in ampicillin and more than 50% in gentamicin. We also have third generation cephalosporins, which have been recommended as second line therapy, but access to that, as we're going to see within the challenges, together with other drugs that have been shown to be effective, are harder to find. So some of the challenges that we face within Kenya and also within the region that has been seen in different studies, we have quite a diversity of clinical conditions. And then also being within the tropical area, there are quite a number of infectious diseases which exacerbate neonatal sepsis. We have clinical conditions such as birth asphyxia, jaundice, septicemia, and diseases such as meningitis and tetanus. Most of the hospitals are low resourced, hence we lack feasible cost-effective cares like provision of basic warmth. You'd find quite a lot of hospitals might not have incubators or have constant electricity to be able to provide this. We also have we are unable to support breathing difficulties that would present within these neonates. And also there is quite a bit of difficulty in taking preventive and control measures in infection. We have also seen, and as mentioned, that sensitivity is mostly seen in more expensive antibiotics such as meropenem and teicoplanin. These are drugs which are harder to come by within these areas, hence posing a challenge since neonatal sepsis affects those mostly within the lower socioeconomic status who are not unable to have access to these higher costing drugs. So some of the recommendations and solutions that we're thinking about as GADP and also working within this program area, we need to have knowledge of the etiological agents, which will help in reducing associated mortality in neonatal septicemia. There is a great need for surveillance so that we can be able to describe the pathogens causing neonatal sepsis and their changing antibiotic susceptibility pattern. Because as we see, we have quite a lot of the antibiotics within our formularies, which have already been shown to have high resistance, but we do not have these changes applied within our guidelines. We also require regular antimicrobial audits and review of laboratory data or surveillance so that we can have proper documentation of drug resistance patterns within lower resource context areas such as Kenya and within Africa. Most of this data is hard to come by, hence it's harder to make decisions in terms of the antibiotic formularies within the region. We also need to have health education to pharmacists, doctors, and the public on the dangers of indiscriminate use of antibiotics, which we have seen is responsible for the emergence of resistance to the commonly used antibiotics. We know there is usually a lot of over-prescribing by pharmacists and physicians over-the-counter medications that are bought by the public. And we found that a lot of this is due to lack of education on how exactly we are able to move into antimicrobial resistance. Then there's definitely a need for prospective studies so as to assess the risk factors for neonatal sepsis, characterize this clinical presentation, the mortality risk factors, and the outcomes of these infants with clinical sepsis. And this has been described by Manika. These are some of the steps that GADP is taking, in which we are trying to see whether we can do a number of clinical trials so that we can be able to assess these risk factors. As mentioned, the neonatal observational study, which enrolled more than 3,200 patients. It was a prospective cohort study of sepsis in hospitalized neonates less than 60 days of age. And with this, we were able to get quite a lot of data in terms of mortality rates, physiological observations, clinical presentation, risk factors as mentioned. And also we had a cohort for the microbiological data. The fosfomycin study, it was an open label safety and pharmacokinetic study where intravenous and oral fosfomycin we looked at the safety and pharmacokinetic profile within neonates below 30 days of age. This study was done in Kenya in collaboration with Kemri Kilifi. And we hope that all this data that we've been able to get up to now will help us in future clinical trials where we were planning to do a larger empiric trial, as has been mentioned. And together with the data that we're getting from our pharmacokinetic and pharmacodynamic studies, we can be able to identify candidates such as fosfomycin and amikacin or other combinations such as fosfomycin flomoxef, which we're hoping are going to be a bit more effective than the current antibiotics that are currently in use. So with this program objective, we're hoping we will be able to work on the multi-drug resistant pathogens. Thank you for your time.
Thank you very much, Bona, for this overview on the situation in Kenya. And it is very worrying if I see the resistant rates at the current against the current first line treatment and even the second line treatment. You said that it's more than 80% resistance for ampicillin and around 75% for the second line treatment. So that really describes that the huge problem of actually antimicrobial resistance and the need for the development of new treatments. With that, I would like to hand over to our next speaker, Dr. Danya Dharmapalan. She's joining us from India. Danya is working at the Apollo hospitals, and she's a consultant in pediatric infectious diseases in Mumbai. And her main area of research is antimicrobial resistance among Indian neonates and children. So this is right on the spot. She's a real expert in this, very well known in India. She has a lot of publications. She's quoted in the main media in India on these issues. So Danya, we are very much looking forward to hear from you something about the challenges in India, the burden of disease in India, and possible solutions. Please.
Thank you, Peter, for the kind introduction. As per 2019 UNICEF data, about 22 babies in India die per 1,000 live births. This is about the average global neonatal mortality rate of 17 per 1,000 live births. Neonatal sepsis is the third commonest cause of neonatal deaths, the first two being preterm complications and labor-related events. Now, though the burden of sepsis is very high in India, we do not have an exact figure because the last national survey was done in 2002-2003. But we do have data from the recently conducted Dennis study, which was done in 3 large tertiary hospitals in New Delhi, where they found that about 14.3% out of 13,500 NICU admissions suffered from neonatal sepsis. Now let us understand how the infections in our newborns differ from that of the West. Firstly, about 70% of these infections occur within the first 3 days of life. Now this is at least 10 times higher than what is seen in USA or many European countries. Secondly, the bacteria responsible for this sepsis belong to a group called as group gram-negative bacteria, and these are namely Acinetobacter baumannii, Klebsiella pneumonia, and E. coli. Whereas in the West, it is the gram-positive bacteria, namely group B Streptococcus. However, another gram-positive bacteria called as Staphylococcus aureus is common to both the settings. Thirdly, these isolates which have been isolated from the blood culture of our septic newborns have shown high resistance to even the first line antibiotic regimen that is recommended by the World Health Organization, and unfortunately sometimes to even the last reserve antibiotics. For instance, in the Dennis study, the multi-drug resistance was to the tune of 15%. Therefore, we physicians have tough challenges to face because of the limited options in the antibiotic armamentarium. In the Dennis study, the leading organisms isolated were Acinetobacter baumannii in 22% and Klebsiella pneumoniae in 17%, out of which 80% of Acinetobacter baumannii and half the population of Klebsiella pneumoniae were resistant to multiple classes of antibiotics. And these bugs have been isolated from the first day of life. The resistance rate may vary across the country from place to place. But from where do these dangerous bugs come from? Unfortunately, due to deep-rooted misuse of antibiotics over years, there is deep-rooted resistance in the community and healthcare settings, and these multi-drug resistant bugs can infect the maternal genitourinary tract as well as the newborn. Then there is a global challenge of confirming neonatal sepsis because the gold standard test, that is blood culture, has a poor yield. Therefore, physicians often rely on the history of maternal risk factors and some laboratory parameters. And therefore, once antibiotics are started on clinical suspicion of sepsis, there is fear to bring them down, and this drives further resistance in the healthcare settings. Unfortunately, even blood culture facilities are not available in many district hospitals. Antibiotic stewardship programs and infection control policies are not robust. And there is unavailability of certain antibiotics which are recommended as first line by the WHO for treating Staphylococcus aureus sepsis, which is sensitive to cloxacillin. So cloxacillin is not available in many parts of the country. Therefore, physicians are often compelled to choose from a lesser effective antibiotic, which may even have more side effects. Many of these antibiotics have not been studied extensively in the neonatal population. For parents who have babies suffering from multi-drug resistant sepsis, it is bad news because of the tough challenges of prolonged hospitalization and increased costs. Please note that 60% of inpatient care is provided by the private health sector. So therefore, it is out-of-pocket expenditure for the majority. And lastly, sepsis is known to have adverse effects on the normal neurodevelopment of the baby. So this is a special age group, the most vulnerable age group, where we need to look beyond survival. We need to look at the quality of life because the entire life lies ahead of these babies. So to summarize my talk, yes, we have a huge burden of neonatal sepsis in our country. Yes, we are facing tough challenges of neonatal sepsis, and we need very urgent solutions. We hope to discuss few of these solutions in today's webinar. Thank you.
Thank you so much, Danya, and for giving us this overview on the situation in India. And thank you so much for pointing out actually the suffering that this causes for the babies, but also for the young parents, and the impact that this has actually for their future life, and another reason why we need to really tackle neonatal sepsis. We are now moving to a discussion, and I'm very glad to be able to welcome Professor Hanan Balki. She's the first appointed Assistant Director General for Antimicrobial Resistance in WHO headquarters in Geneva. She is a professor of pediatric infectious diseases with over 2 decades of experience in the field of IPC, infection prevention and control. And that gives me actually a good excuse to direct the first question to Professor Balki. Hanan, we heard from Manika the need for new drugs. Borna really showed us this very impressively with respect to the resistant rates in Kenya and also Danya for India. But then, I mean, yes, treating neonates to get infected is a priority. But what about infection prevention and control? Can you give us some hints on what can we improve from your clinical experience?
Thank you very much, Peter, and thank you everybody for the great summary and presentation, and really being very focused in your presentations and summarizing the crucial entities, which is lack of medications, IPC, poor research and development in this area. So, and thank you for focusing on IPC, because when we look at the types of pathogens that were mentioned by my colleagues, some of them are actually environmental ones, which means that they can be found either in the environment, in the water, in the sinks, in the humidifiers. So the intricacies of infection control are, which means infection prevention control. For those who do not know what that is, that's a discipline that exists in the healthcare settings, and their role is to be dedicated to the discipline, hopefully, and to put policy, procedure, and audit and follow up on the practices of the healthcare workers, families, and patients when they're older enough, to make sure that there are no breaches in practices that allows for these infections to be transmitted within the hospital environment. Now, the neonatal areas are even smaller enclaves within the healthcare settings, and there's a lot of peculiarities about what goes on in those environments. Examples are similar to what happens in the adult ICUs, ventilators, laryngoscopes when you want to intubate a child. They all need to be cleaned. Neonates are put in isolates, they're put in incubators, they need to be cleaned. There's laundry, there's expressed breast milk securement, there's the kitchen and providing feeds for the babies. So you can imagine the multiple opportunities for breaking good hygiene practices that will allow for transmission of these pathogens. So I don't want to get into the details of the discipline itself and what needs to be done, but the message I would like to put out is the extreme relevance and importance of this discipline for the healthcare facility leadership to allow for this discipline to exist, thrive, and practice so they can guide healthcare workers and families on best practices to prevent unnecessary transmission of these pathogens. I'll stop here, but I can add later.
Yeah, thank you, Hanan, for giving us this introduction on the importance on infection prevention and control. And we do know that every dollar that you are investing in IPC is actually a good investment. And that is maybe also the difference versus R&D, because developing new drugs is we invest a lot of money, and you cannot be sure that something that you actually are going to find the new panacea. And in particular for we heard from Danya that there's so many different bacteria causing neonatal sepsis, and these bacteria vary from one country or region to the other, including the resistant rates. So I wanted to ask you, Borna, what do you think the observational study that GARDP is doing, what is this going to tell us for the challenge of developing new treatments? And how can we expect to have one new treatment which will be a global treatment, or do we actually have to use different combinations in different countries, in different regions, depending on the level of resistance and also depending on what are the bacteria that cause neonatal sepsis in these countries?
Thank you, Peter. I think one of the great things about the observational study was that it was done in different areas across the world. And this would also provide us data in terms of the etiological data and also these pathogens that are presenting, because you would find that neonatal sepsis and the infections in Kenya might not be the same as those in South Africa or in Thailand or Brazil. So the observational data is going to the observational study is going to provide us with data in terms of which pathogens are where, and also their susceptibility in through the microbiological cohort that we had. This will assist us better in targeting the antibiotics so as to ensure that we are working on the correct pathogens in the correct regions. It's highly unlikely that we can have one antibiotic that is applicable everywhere, because if you're to look at countries like Kenya, where we're still using ampicillin, gentamicin, despite the high resistance, it means we have not been exposed to the other, might say, stronger antibiotics. So it makes it easier for us to use other classes of these drugs. But if you're to look at other countries or high-income countries who have been using most of these antibiotics, then they would need a different combination so as to be able to fight neonatal sepsis. So I think we're going to get quite a lot of data that would help us. It's a form of surveillance on our end to see what our doctors are using, whether it's in the rural district setting, whether it's in our referral hospital. And once these prescribing patterns have been put in place together with this data, then we can make better decisions in the correct drug for the correct region.
Thank you so much, Borna. Yes, we definitely, I mean, we actually lack the information. We don't even know what is really used in different countries, in different regions in terms of drug combinations and what are the underlying reasons. So we really look forward to the results of the observational study that I understand are going to be published soon. And I do think that they will also inform the needed revision of the WHO treatment guidelines. Because we do need this information to actually be able to update those guidelines. Danya, what can you tell us about the possible solutions in India? What would be your 3 things you think that should be implemented and try to be implemented in hospitals?
So we need multi-pronged approach. First is we need to save the babies who are now currently suffering from multi-drug resistance. So we are looking forward to the new antibiotic regimens by GARDP. Secondly, we must understand that the sepsis resistance rate vary across the country. And so we need more studies, especially in how is the situation in the community, how is the situation in the rural populations. If there is no blood culture availability in the district hospitals, then it will be difficult to understand what's really going on. So we need more of surveillance studies. Secondly, we need to prevent further antibiotic resistance by improving the judicious use of antibiotics. The major reason for prescribing irrational antibiotics is the fear of the physician of going wrong. So we need to address that situation by helping with a very good clinical tool by revisiting probably the basics, as well as finding a good diagnostic method to help them confirm the sepsis. And thirdly, infection prevention is extremely crucial because that acts as a perfect fuel for spread of these multi-drug resistant bugs. Hand hygiene, it's in our hands. Hand hygiene has to be encouraged and has to be hammered in the minds of the healthcare workers. They should understand why they should do the hand hygiene, and that itself will reduce, I think, the hospital acquired infections by 40%. So there should be leadership support. There should be early promotion of breastfeeding. There should be improvement in the staffing of the NICUs. So infection prevention, yes, a major contributing factor as a solution.
Yeah, thank you so much, Danya. Yes, we are coming back to IPC, but you also mentioned one important point we didn't touch upon before, was the irrational use of antibiotics. That is actually driving the development of antimicrobial resistance and making the problem actually worse. Manika, can you tell us, I mean, when can we expect new treatments for neonatal sepsis from your programs? You showed us that you are having 2 strategies. You're looking at brand new drugs that are developed from scratch, but you also look at old antibiotics that you may be able to actually repurpose for treatment of neonatal sepsis. How does that work, and when can we expect something?
So first of all, I just want to make a point to say that one of the reasons why we have if we can call it irrational use of antibiotics, particularly in the management of populations like neonates, is because we don't have data to guide clinicians all around the world how to appropriately treat neonates. So I think it's very easy to tell people you need to do a better job, but if you don't do the basic level of surveillance and you don't do your research and you don't develop new tools, you're going to leave people who have to manage the situation of newborns all around the world in a very difficult position. And so obviously, I totally understand why people would escalate and use drugs like meropenem if they had the ability to access drugs like that. I have to make that point extremely clear, having been a physician who's been put in that position in many different circumstances. The second part is that, unfortunately, there has been a chronic underinvestment in the entire field of pediatrics and neonates, not just in antibiotics, but across the board. But it's acutely, I think, severe in the field of antibiotics. So we have a lot of catching up to do. We have to understand that some of the even old antibiotics that are now generic have never even had a neonatal indication. They never even had the research done to identify how best to use these kind of antibiotics for the neonatal population. When you're starting this far behind, you have a serious problem. So we have a lot of catching up to do. And we even have to do the basic information to understand what is the nature of the problem we're dealing with. That's why the first thing we did was start with a big global observational study, so that we don't start, going down rabbit holes and chasing the wrong, going after the wrong diagnosis. What we intend to do now at this point is to look at two or three axes of work. First of all, from our side in GARDP, we want to work with partners to basically strengthen research capacity across the world. And this new observational study is a very important kind of backbone for that. And we hope that that will also encourage sites to do other kinds of research that are also important, not just R&D into new antibiotics. Secondly, we obviously will want to look at how we can improve management in the short to medium term. And there we have to look at, obviously, existing antibiotics. So we are now planning a big study to look at combinations of existing antibiotics and how they could potentially be used to manage neonatal sepsis. And this may include drug-resistant infections as well. And we hope to be able to conduct and do this study over the next 4 to 5 years and have results that can actually change practice on the ground level. But of course, what we're also looking at is beyond that. So we have to look at drugs that have just recently been registered, but also drugs that are now coming through the pipeline. What are the most promising? And accelerate the pediatric and neonatal development and integrate that into, I think, treatment algorithms that will emerge from this other trial that we're planning. So we will have to, it's work that has to be built layer by layer. Now, in parallel to that, I'll just finish by saying that with our partners, we're also extremely interested to support other studies, including studies on IPC. So any research that could look at improving IPC is something that we will support in the network of studies that we're doing. So we will try to build on this. Last but not least, I would add a point that we haven't mentioned this point yet, but I think diagnostics are very important for the future. We need to invest in diagnostics for the pediatric and neonatal population. And we also need to just invest basically into neonatal care. One of the most shocking things that I've seen is just the lack of space in neonatal units around the world. This is a big risk factor for infection. People often miss this, but we have seen a huge level of urbanization, hospital-based births, and in fact, improved survival in the neonatal population. All important things and things that are fine, but this will have the impact of significant overcrowding and stress in neonatal units. So in parallel to doing research, I think we have to invest in neonatal centers around the world.
Thank you, Manika. You touched upon so many very important aspects. I mean, and one thing you mentioned is that there is very little investment in developing treatments for infections that of very young children, neonates in particular. And that is something where the public sector has to invest. And so we are very grateful for the governments and foundations that are funding GARDP. And there are a couple of governments that have been doing so over the past years, but it's by far not enough. So we need more governments to really take this serious, provide some resources so that foundations like GARDP can continue their work developing these needed treatments, because the private sector is not going to do so. But I wanted to pick up on your last point. You said we need more investment in neonatal care, and Borna, you showed us a slide where you said that there's lack of feasible care. And how do you see that? I mean, if we would just develop new antibiotics, introduce them, but then, as Monica said, there's not enough space even in neonatal settings, and then the resistance is going to develop very rapidly against the new treatment, and we are going back to square one again. How can we break out of this circle that we are going to develop new drugs, but we are also changing the whole situation, that we don't infect so many babies with resistant bacteria?
So I think we do require a holistic approach when we're looking at it, because as Monica mentions, if we look at our low resource contexts and just having no neonatal ICU beds that are available, or having a neonatal specific unit with enough beds, that is enough to increase the neonatal mortalities within that area. Then if we go back to Hanan's and Danya's discussions where we talk about IPC measures, if we have the facilities in place, but we are not able to sterilize this particular equipment, if the physicians or the nurses are not practicing good hand hygiene, if we do not have prescribing measures that are put in place within the hospital that allows for the MR stewardship being applied within the hospital, because we are not thinking of an ICU unit or a neonatal unit by itself. We have to think of the hospital by itself, because these are cadres of healthcare workers who move around. So the approach needs to cover all these different areas, and with this would require, like within the hospitals, to have like an AMR champion, so as to ensure that as we are working towards the research and development of new treatments, as we're trying to repurpose new drugs, that these drugs will find settings in which as we use the new drugs, we are not creating resistance to these new drugs. At the same time, we are not finding measures to ensure that we are able to keep these drugs. So that would be my recommendation, to have this approach that is worked on by different cadres and is worked on by different stakeholders. Yeah.
Yeah, thank you. Yes, I think we need to change the perspective. Often people see investment, I mean, they see it as a cost. While it's not a cost, it's a good investment. And maybe COVID-19 is going to convince more people that upfront investment in health infrastructure is actually a good investment, and that you're going to save money when there is a pandemic, but also with respect to antimicrobial resistance, which is a slow-moving epidemic, that this is actually a good investment. And in reality, you're saving money and saving lives in the end. Danya, what do you think about India? Is the situation comparable to Kenya? Is there something that how do you think you could convince your government to invest more in investing in health infrastructure?
Yes, so more research studies will help convince, because when there is a discussion, there's always a question, so where is the data? So firstly, we need data to convince them. And secondly, as you rightly pointed out, COVID pandemic has helped people to understand the importance of hygiene, hand hygiene, respiratory hygiene. So we can take advantage of that, and we should start moving in direction of infection control, public education, healthcare education. The situation would be similar, the solutions would be similar as in Kenya or in other developing countries. But I think that's the only way to go about. And if there is support from the WHO, that would be kind of really great for the governments to act quickly. So Hanan can probably add more on that.
Yeah, Hanan, you are our AMR ambassador, and you are our voice, and I think we have been more yeah, we have been making more noise, but certainly WHO can do more. Hanan, what are now the next steps?
Thank you very much, Dania, Borna, and Manika. I think your comments are very close to my heart because this was my past career, as you all know. This was my daily business in a way. I think I would like to encourage all of you and the audience to log on the DG's presser today at 3 p.m. Central Time. Very, very important event is happening. Again, we're in the middle of World Antimicrobial Awareness Week, where we have changed it from antibacterial to antimicrobial to be more inclusive. We fixed the dates of this specific event. And as you know, the AMR division at WHO is a year and a half old. And we were inundated by COVID, so we were a bit slowed down. But the presser today is going to be something that I'm sure will be very exciting for all of you to please log on. We completed the interagency consulting group, which was announced by the UN UNGA in 2016, and part of those 14 recommendations was enhancing the governance for AMR, the global governance for AMR. So again, for somebody like me, like you, in my previous job and your current job, we're struggling at the front line. There needs to be the leadership endorsement and adoption of this specific topic. So the Global Leaders Group for Antimicrobial Resistance was one of the recommendations of the IACG committee, and it will be announced today. We went through a very tough past 6 months to announce their terms of reference, and so please stay tuned for that. Now, once this Global Leader Group has been announced, we expect that they will be our expanded ambassadors to draw the leadership attention to the topic of AMR. Two other global governance entities are going to be established very soon. One is the panel of evidence, and that's the one that will be extremely helpful to guide us on the deficiencies, gaps, and where to go when it comes to research and development, surveillance, burden of disease. How do we really continue to frame the scientific knowledge and I prioritize those gaps to be addressed on where we need to go with the AMR agenda. And the third platform is the partnership platform, which will come at a later stage. So I think with that in mind, that we finally reached this point, it's a very exciting day for me specifically because I was a member of the IACG committee and now heading the AMR division at WHO. I feel that there definitely needs to be a huge support from the global leaders on this topic. The other thing is that the AMR, we're talking about a very specific area, the neonatal part. But again, the neonates and their mothers and the healthcare providers are part of that larger community. So the misuse of antibiotics in the mothers and the healthcare providers, the unintended exposure by being colonized with already resistant genes is really a challenge that this topic needs to be addressed in a holistic way, Dania, as you said. So I think once we have that global leadership in place, hopefully we will be able to bring more healthcare for the human health specifically, more of the health leadership on board to this very important topic.
Thank you, Hanan, and thank you so much for actually mentioning today's press conference. So if you're wondering where to find it, you go to the WHO website, you go to the COVID-19 section, and there you can watch the daily press conferences, or they are not daily anymore. But today, it is not so much focused on COVID-19. Today, there will be Dr. Tedros actually launching, together with the Director Generals of the Food and Agriculture Organization in Rome and the Organization for Animal Health in Paris. They are going to launch the Global Leaders Group for AMR, and I can already reveal that it's going to be chaired by two prime ministers, the prime ministers from Bangladesh and Barbados. So I think that is really, really a group that is going to enhance the global leadership. We hope that it's going to mobilize more resources And for all these different things we have to do, whether it's drug development or IPC, awareness raising, development guidelines. So we really think that this is a major step in the fight against AMR. So if you want to join, it's 3 p.m. European time on the WHO website. And having said that, I think we can move to the questions from the audience. And I already received one for Danya. You mentioned that most bacterial species causing sepsis are gram-negative. And the person who was asking this question is wondering why that is the case in India. And some of these species you mentioned can be classified as coliforms, and whether there's a link, he's wondering whether there's a link between the economic situation and the kind of bacteria that are causing sepsis in India.
Well, there has been a lot of discussion about why the gram-positive bugs are not seen predominantly in neonatal sepsis, especially group E streptococcus, and it has been also discussed whether this is underreported from India, because group B streptococcus occurs very early in life. But there has been several studies which have proved that the percentage is just up to 6 to 8%. Now, actually, why only the gram-negative bacteria? Maybe the a cause of sepsis is basically from the health environment. So as I said, because of the irrational use of antibiotics, it's just that the resistance in the gram-negative bugs have increased to an extent that they are infecting the newborn or the materno-genito-urinary tract. So basically everything boils down to irrational antibiotic use. We all know that India is one of the largest producers of antibiotics, but somehow there had been no check on how the antibiotics were prescribed. You still get over-the-counter availability of antibiotics. So I think all this is interlinked. Plus the public education about antibiotic resistance continues to be poor. So they tend to self-medicate, or they tend to take treatment from the quacks. So that is also another important area to focus on. Maybe because of the low literacy level, yes, that could be related to the economy, but we need to kind of educate the public about resistance. I'll just give a small example. Like in US, when they talked about the antibiotic use in poultry, when the public awareness increased, automatically all those big giants like all McDonald's or Kingfisher started advertising that their food does not contain antibiotic, their meat does not contain antibiotic. So if public education and awareness increases, that itself will tilt and pressurize the government, the healthcare workers to be careful when prescribing antibiotics and be more judicious and responsible.
Yeah, thank you, Danya. Coming back on this very important problem of irrational use, and that is a really complicated problem to tackle, because I mean, even in Switzerland, where you have a German-speaking part and the French-speaking part, the French-speaking part continues to take 30% more antibiotics in the community than the German-speaking part. And this is not because the French-speaking people are more sick. It's just because they take more antibiotics, and it's the doctors, it's the patients, it's the parents who want antibiotics, and they have been running awareness campaigns for a long time, but you can see over the past 4 years, it's stable. The discrepancies are still there, and it's not going down. So I think that is also an area where, as WHO, maybe we have to think about doing some research. How can we be more effective? I have a question for Borna. What are the antibiotic stewardship activities in place in the hospitals from which comes the resistance data you presented? Simply introducing carbapenems and other new antibiotics is a short-sighted strategy, as resistance is bound to escalate soon, particular to carbapenems if used under the usual conditions, unfortunately found in many resource-limited settings.
So in countries like Kenya and also within the region, there have been quite a lot of push in working on the AMR national action plans, in which we are trying to increase antimicrobial stewardship within the regions and within the country. And with this, we are hoping that we would be able to ensure that we do not get more resistance to antibiotics, even as we introduce the antibiotics within the hospitals. So some of the AMR measures that have been put in place that are being also pushed for is having, as mentioned before, having AMR champions within different public health spaces, and also having antibiotic policies that are adhered to within these hospital settings. And this would ensure that antibiotics are prescribed after you have a specific pathogen that you're working on. But this also poses a problem because we know the diagnostic capacity within this region is also quite low. And one of the reasons from studies that have been done in which physicians tend to overprescribe medication or provide empiric treatment is because it takes quite a bit of time to be able to get culture results or to do any other diagnostic measures for our patients. So having the availability of these rapid diagnostic measures, having antibiotic policies in places, and also just for the doctors, just ensuring that within our undergraduate and postgraduate that we are already talking about antimicrobial stewardship. We're hoping that this would be applicable even as they start practicing, and to ensure that antibiotics are used safely and at the correct time.
Yeah, thank you, Borna. I have another question for Hanan. Are there studies and trials of the effectiveness of the different infection and infection prevention and control measures? This is often the most difficult science to do, but is necessary so antibiotics don't distract caregivers from IPC.
Thank you. That's a very good question. And I think definitely there's not enough of research, but I think that there's plenty of research on the impact of hand hygiene. And I think that, I don't know what type of research that we would want to do, whether to test whether we should sterilize equipment or not. So even when we're talking whether that's ethical, I don't think that that's even ethical. But I think the type of research in IPC that is definitely needed is the trends and the clonality of the pathogens. A previous question talked about why this specific gram-negative or the other. And I think it's very important that we are able to do research to show the actual spread. There were studies done looking into, I don't know if they included children, but they looked at people entering the hospital and to see what are they colonized with. And when they were discharged, what were they colonized with? So that's an indication that they picked up these pathogens within the healthcare setting. So there's a huge gap in epidemiological research on IPC and AMR, and specifically when you want to talk about the Enterobacteriaceae or the pathogens that are like Acinetobacter, Proteus, not necessarily the Klebsiellas and the E. coli's, but some of the other environmental pathogens. So we would like to see more research on that. And I think that's when I was speaking about the panel of evidence that we hope to establish as a guiding group to help advocate for the need of these epidemiological studies that do not necessarily get a lot of attention because they don't go into the most prestigious journals. They're not very, if you will, exciting to do. And they are difficult to conduct. So I do hope that we see a boost in that type of epidemiological research.
Yeah, thank you, Hanan. Two small questions for Monica. How can GARD-P incentivize and encourage pharmaceutical companies to develop antibiotics for this unmet need? And will the new drugs that GARD-P is developing, will they be affordable in low and in middle-income countries?
Yeah, so I'll take the first question. Second question first, I think it would be extremely important to ensure that these drugs are affordable, of course, and that they are available, so that we are ensuring that they are registered and available in key countries where I think they're needed most. And I think we're working on access initiatives to ensure how we can, at the one hand, accelerate the pediatric development and ensure we can do the relevant public health trials and evidence generation. Secondly, to look at registration at country level, and thirdly, to also look at how we can ensure, I think, supply of these antibiotics. So this is not a small issue; it's a very big issue. We're trying to work with other partners on this. Of course, we need to work very closely with pharmaceutical companies. I think they will be a key partner here. And what we are trying to do is really actually do two things. First of all, work closely and support and fund if necessary, and put the resources on the table, and even take the responsibilities for studies that will be required for the pediatric and neonatal development. And we recognize, particularly for smaller companies, that this is a challenge, but even for larger companies who have to justify, I would say, the existence of their antibiotic portfolios, this is something that, of course, can help to accelerate the pediatric development. And the second thing we try to do is develop a more holistic, wider relationship with the company. So to look at other areas of how we can support the development of that antibiotic and the access of that antibiotic. So outside the pediatric development, can we do other things that can accelerate the global development and access of that antibiotic? But I have to say that I agree with your comment you made, Peter, earlier, that I think that we need a lot more incentives and public investment, particularly in the area of pediatrics and neonates. And it's very concerning to see how little, I think, attention this has received. If you look at, these broad figures of 700,000 people dying every year, and an estimated 200,000 to 300,000 neonates dying every year from drug-resistant infections, you can see that this is one of the most impacted population here. And obviously, being newborns, this should be a priority population, both from a social and economic perspective. And yet it's not. It's the last in the line. And I think it's really shameful, and I think quite sad, how little investment is going into this space. And I strongly call all public and private actors to do much more to support GARDP and others to actually accelerate research and development of antibiotics and other essential tools for children and newborns, really to address this problem in AMR. In particular, I think the call you made, Peter, for governments, we need much more resources. I think one thing that could help is if there are incentives for antibiotics, ensuring that these public incentives can tie perhaps, or I would say further incentivize companies who actually will be willing to put resources and support and partner with entities like us to do the pediatric and neonatal development. So that's something that we could look at. If we have a look at full incentives in the future, this should actually have some conditions to ensure that there will be some prioritization for the pediatric and neonatal populations.
Yeah, thank you, Manika. I mean, I couldn't agree more. It is the system. I mean, drug development is incentivized by return on investment, and you don't get a lot of return on investment in treating neonates. Although, I mean, we should actually make so many efforts to actually save these children, and we just don't do enough. I mean, and even, I mean, if I look at the global WHO report on the burden of sepsis that we published 2 months ago, it says that actually 84% of neonatal deaths due to infections could be prevented through measures such as early diagnosis and appropriate clinical management. So it's really feasible. It's not something that we don't know how to do it. We know how to do it, but we don't do it. And that is, as you said, shameful. I wanted to pick up on, I have 2 questions around diagnostics and stewardship, and I'm really intrigued because we heard from Danya and from Borna that there's so many different bacteria causing neonatal sepsis, and we have resistance levels are varying. So how do you see, and also to you, Manika, do we need new diagnostics, and what kind of diagnostics? And then of course comes again the question on, will they be able to be used in settings in less, I mean, in low income settings? So how do you see the role of diagnostics in relation to drug development? And maybe I'll ask Danya to start off, and then please feel free.
I think molecular diagnostics have a big potential because they are rapid. Now, for example, GeneXpert has revolutionized the way we manage tuberculosis, or rapid malarial antigen tests have helped for managing malaria. So similarly, maybe some PCR test to diagnose rapidly neonatal sepsis, as well as give the causative organism. That should be the way forward, and that which should be made, if that is made economical and feasible and reachable, just like accessible, just like GeneXpert, then that would be kind of a great situation for the physicians to diagnose early.
Manika, do you think such a diagnostic, is that feasible to develop, that is giving you actually as a rapid diagnostic the underlying causing organism, and then you can target the appropriate antibiotic treatment?
Sure, I think of course it's feasible. If you look at the amount of progress that has been made in COVID-19 over the last 9 months, I think necessity is a mother of invention, as they say, and I think I think it's much more now that we need to now focus on what are the global public health risks that will be emerging in the future as we start to look beyond COVID-19 and start to think about what other pandemics and global infectious disease threats we have to deal with. We have to start investing, I think, in diagnostics. I do hope that, in fact, that the huge investment in diagnostics made from COVID-19 may actually allow some technological progress that has been made in the field to be then shared and opened up to the AMR space. For sure, pediatrics and neonates, there are obviously problems in this population when you think about the volumes of blood you can take and sampling and so on. But I think these are challenges that can be addressed, and I think Danya mentioned there are already some avenues that one can look at. And I do strongly believe that all these technologies can be available in low middle income country settings or adapted if there's sufficient investment. If we look at the huge work that was done in malaria and TB and HIV, I mean, this shows that it's possible. 20 years ago, when I was working in a sub-Saharan African countries, I was told by professors of international health that using diagnostics for malaria was not feasible, and microscopy was the standard and so on. And we've moved beyond that. So I think it shows what can be done, and I think we will move into this space. I think by sheer necessity, we have to have much more targeted antimicrobial chemotherapy. We are seeing a much more complex epidemiological picture, and we have to compensate for that by improving our diagnostics.
Thank you, Manika, for this positive spin on diagnostics development. I have a question for Hanan on WHO. Studies around the world talk about the antimicrobial resistance and neonatal sepsis by MDR pathogens. Isn't it time that WHO changed its recommendation on choice of antibiotic for empirical therapy in neonatal sepsis?
Yes. Yes, the answer is yes. I think this is a question that we've been trying to address for some time now. And again, going through the routine methodologies of developing the guidance development group, the GDG group. And I hate to say that, unfortunately, we were delayed with COVID due to the massive work that has been going on for COVID specifically, and the major repurposing of a lot of us into COVID. But I think again, a new announcement is that the AMR STAG committee has been revamped, and we've announced our members of the STAG committee, and this is one of the areas that will be tackled and addressed by them, where we're already putting the pieces together to start the GDG moving forward with revamping these guidelines. The guidelines need to, once they're established, there needs to be a methodology again to ensure that the proper diagnostics and therapeutics are available for the countries. And then that will not take away or solve the whole problem. I think Danny had mentioned this, or Borna, when we talk about availability of diagnostics at the bedside, whether they're your traditional diagnostics or whether we end up having innovative diagnostics, the initial, the therapies go for the audience goes through the immediate treatment that you want to give a child without have, or a patient, whether a child or an adult, and then within 2 to 3 days trying to identify what specifically is causing this infection for the patient so that you can shorten the list of antibiotics that you're giving to that child, which we call de-escalation. So you give more focused therapy. And even when the guidelines are changed, I hope that they will address this issue of empiric therapy, or the immediate treatment that you would give, and what are the options for shortening down or for focusing the therapy so that you don't unnecessarily kill a fly with a bulldozer when you can hammer it down. That's the simple example, is that you don't need the big guns to treat a pathogen that is responsive to a very specific antibiotic. So it's a very specialized area, Peter, and I think that the guidelines is a missing piece of it. But what also needs to be complementing this guideline piece is what exists at the healthcare setting of diagnostic ability, clinical interpretation ability, so the right skills among the healthcare providers, and the availability of the drugs in the hospital pharmacy. So all of those issues, and the monitoring process. So yes, we hope that we will be able to address that within less than a year, I hope.
That's great news, Hanan. And these are not the only guidelines we have to develop. We have, I mean, it's very obvious. We are far more advanced in TB, HIV, malaria, where we have WHO global guidelines to treat, and they are regularly updated. And we do not have these guidelines for most of the bacterial infections, and that is a gap that we have to close. We are working on it. You will see that early next year, we hope to be able to publish a handbook on how to treat bacterial infections, which is, let's say, something which is falls a bit short of a guideline, but it's also easier to use, and it's going to cover most of the bacterial infections. And also to add to the answer of Monica on the questions around access. We are also working with GARP as well as with UNICEF and CHAI on an initiative how to improve access to existing antibiotics, to old antibiotics, as well as new antibiotics in low, middle, and high income countries. Because we are seeing today that even countries in Europe have difficulties to procure and access antibiotics that are often in shortage, like benzathine penicillin or PIP, TAP. But we also see similar problems in low and middle income countries. And we do want to create, actually, building on existing structures in UNICEF, we want to create a facility where countries have easy access to quality approved first, second line and reserve antibiotics. And so that is something we are working on, and we are very excited, and we hope to make fast progress. Having said that, I think I'm not able to summarize the discussion. I learned a lot, and I think one thing that I learned is that to be able to move on neonatal sepsis, whether it's on drug development, on developing the guidelines, or whether convincing governments to actually invest in healthcare, what we need is data. We need to know more about how many babies die, why do they die, what are the underlying pathogens that cause the infection, what are the appropriate IPC measures to prevent that these babies get infected, and what are the best measures that we can take. And only if we have more information, more data, then we can also develop the appropriate combinations through GARD-P. And we also can make sure that the new WHO guidelines are actually really appropriate, because that is the major challenge. We cannot afford to update guidelines and then recommend treatment that doesn't work in half of the countries. And having said that, I would like to hand over to Hanan for your concluding remarks. Please.
Thank you very much, Peter, for the very well-run session, and thank you for my colleagues, Manika, Dania, and Borna, for the great presentation and the engagement and the perseverance on this very difficult and, as Manika said, neglected area. I hope that we will be able to work together more on this, and that the WHO specifically gets way ahead of the curve on some of the guidance that is needed and the technical assistance. We didn't talk about the antimicrobial stewardship tool and the governance for that. That's also coming out. And I think the book that you were mentioning, Peter, I think that it's coming out this week or next week. So I think it's more imminent than we think. Our colleagues in EML have worked on it. And again, to re-emphasize that the WHO, and specifically since I've taken this position, it was very important for me to focus on the global governance of AMR, because we've been struggling in kind of, the little people trying to struggle at the end of the foot of the mountain, trying to scramble to do whatever we can with infection control and this and that and the other. But without the global leadership engagement and acknowledging that AMR is an existential threat to human health, we will not be able to move forward, and we will continue to have these small side shy discussions about a topic that is already a pandemic, that already has a million faces, not one face. We're not talking about one pathogen. And I think that sense of urgency in bringing this message out needs to come from a different group of people than ourselves. And that's the whole reason for us to push really hard for the Global Leaders Group and continue to support all of you who are working on this topic. So thank you for joining us for this webinar. And I hope that within a year from now, in our next WOW, we will be able to report on major advancements in this field. I hope so. Thank you, everybody.
Thank you, Hanan. And yes, you mentioned it. This is part of the World Antimicrobial Awareness Week. So thank you all for joining. Thank you to the panelists. It was fantastic. I very much enjoyed it. I hope you did so too. Goodbye.
Thank you.
Bye-bye. Thank you.
Bye-bye.